PMC podcast, where we look at pediatric rehabilitation and the latest advancements in special needs care. I will be your host tonight. My name is Amr Said. I'm a pediatric physiotherapy specialist. And I have a very, very special guest today, who is Dr. Nadia. Welcome, Dr. Nadia.
Thank you very much, Amr. Thank you for having me.
Thank you. So please tell us and our audience a little bit about your specialty.
My specialty is called physical medicine and rehabilitation. And from the name, the physical medicine aspect, it talks about the musculoskeletal medicine. So muscles, joints, how they interact with each other, mechanics, how we walk, how we sit, all of these things. Mm-hmm. Rehabilitation part, of course, it's rehabilitation of anyone with physical limitations of whether communication problems, movement problems, walking, all of this. Mm-hmm. And my subspecialty is pediatric rehabilitation, which is doing all this for children with special needs.
Great. So your specialty is more focused on pediatrics,
yes.
But you also treat adults.
Yes.
Right.
True.
Right.
Yeah.
So from your perspective, what's the difference between older patients and smaller patients?
That's a good question. Of course, I'm biased, but I have to say I like that I can treat adults and kids because I can take care of the kids even after the age of 18. Great. So it allows continuity of care. Once I know the children, I keep following them until they're 20, 30, 40, however I'm able to live, inshallah. Because children with special needs, as you know, they have a spectrum of aches and pains and disorders that no one else has. The specialty allows me to understand that and help them throughout life and go from one stage to another. How is it different in adults? I want to say that children, this is how they know life. They want to thrive, they want to play, they want to get better. So it's actually easier, it's much more rewarding. For adults, no, it's different because they knew how life is before disability. So they keep comparing what they, life before and after and remember what they lost. Yes. So it's a bit different.
Yeah. And of course, with pediatrics, you are dealing with a developing human being. So they are learning things in a different way.
Yes.
Which they, as you said, it's not the normal thing that they are trying to go to. They are experiencing the world, but in a different way. Mm-hmm. Yes.
Yeah. And they have so many surprises and beautiful things to show you as they grow. Yes.
Every milestone, every achievement is big. It's big for the family, for the whole family, not only for the patient. Our title for today is the use of Botox and Phenol injections for children. So in the beginning, we work in a frame of work, which is the International Classification of Functioning Frame of Work. This frame of work, it classifies all the systems for each patient so that every system is different. So about the ICF, International Classification of Functioning, we look at, this is a universal language so that each specialist, each member of the healthcare institution, we should talk to each other in the same language. So this makes it easier for each one of us to speak to each other, to have the same language, to know what we are saying. Like if we are discussing impairments, if we talk about impairments, it means that the structures, the problems in the structures or the functions of the child. But if we talk about activities or participation, we're talking about the functions that the child does in his daily activities. So if it's whether they are brushing their teeth, eating, walking, all of that. But structures and functions, we're talking about the length of the muscles, the muscle tone, how the coordination, how the brain controls the body. These are all examples. So when we deal with patients, we deal as a team. And we have very common terms that are used, which is multidisciplinary team and interdisciplinary team. So Dr. Nadia, can you tell us what's the difference between both?
They're both not very different from each other. So multidisciplinary, it just means that there's more than one subspecialty taking care of the child.
Yes.
The interdisciplinary, it means that, as you said, they speak the same language, they have the same plan, they have everything
Yes.
together.
Yes.
And of course, when we take care of our children, we prefer both, or like interdisciplinary, of course, because we want everybody's opinion, everybody's view matters, because you as a physical therapist, you know what you're doing, you know the child very well, you work with them very closely, the occupational therapist, the speech, all of that. And I think it's very important for me as a physician to get feedback from the entire team in order to see how can I help you progress, or how can I help the child progress.
Yes,
and which is my job.
Great. Yeah. So dealing as a team about the child, we focus on all of these systems to try to treat the child in a holistic approach or holistic way as a whole, because we are not treating like only ankle pain or only muscle spasticity. We are treating the child as a whole, because each problem has an impact on daily functions. So this brings us to patient-centered care. We the treatment has to be centered to the patient, has to be looking at the patient this way, and the goals has to be also related to the child's and the family's goal-oriented treatment. So there are sometimes single system affection and multi-system affection in pediatrics. So can you tell us also what's the difference between them, single system and multi-system affection? Like sometimes a child can have a completely motor problem. Sometimes the problem can involve more than one system, like motor or sensory or cognitive, right?
Yeah. Of course, it depends on, every child is different, and it depends on the initial injury. Where did it happen? Most of our children, they have mainly motor problems. And of course, motor problems don't only affect the arms and legs, they affect also the gut, they affect the bladder, they affect quite a few things. And again, so the children who have both arms, both legs affected, they're more likely to have the swallow also affected, their speech, other stuff, and they're most likely to have bowel and bladder issues. The children who have, for example, there are children that have one leg involved. There are children who have two legs. So in that case, yes, you're only dealing with that problem. So of course, the extent of the systems affected is gonna dictate how many people are taking care of that child. Is it one specialty? Is it only rehab? Or is it going to be rehab, the lung doctor, the stomach doctor? So really depends on the complexity of the child's situation. You would need the help of more and more specialists in the case.
Yes. And this brings us to the most common diagnosis that we face in pediatrics, which is cerebral palsy. And most of the time it involves, it is complex, because each child with cerebral palsy is different. And it depends on his skills in each of these systems and each of these domains. And that's why we all go to the gross motor functional classification system, which is very good to classify the functional abilities of the children and into different levels, so that we can track their prognosis, track their improvements, and help us have one goal as a team to reach and to work on. One of the most common also problems in cerebral palsy are pain as a symptom. So do you face that, and do you work on that in your specialty?
So yes, there are quite a few reasons for a child to have pain, and it depends on when it happens in life as well. If it happens at the very beginning, usually the parents bring the children and say, I cannot position them, he can't sleep all night, he keeps crying, needing to be repositioned. We have to keep in mind that the children, many of them are nonverbal. They cannot tell us. So we have to have high suspicion of, or high, an idea on where to start to look for pain. So the pain can be just the spasticity or the muscle spasms.
Yes.
It can be the joints, or it can be just like the hip, if the hip is subluxed or dislocated. It can be the scoliosis that causes lower back pain, muscular pain, difficulty with positioning, and let's not forget that it can also be their stomach. It can be severe constipation and they can't tell us.
Yes.
It can be headache, so there are so many other reasons. So all we can do, especially with nonverbal children, is observe and treat as we are observing and see the effect of it.
Yeah.
So mostly at the beginning, it's spasticity, and then once the child is older, if they have contractures, if they have hip subluxation, then we start to suspect that as well.
Yes, yes.
When they grow, like in their 20s and in their 30s, we start to think about arthritis because they get arthritic changes earlier than the rest of the population, just because there's an uneven force and an uneven pull on the joints.
Yes, yes.
So they're more at risk for it. So we should kind of measure and see the situation. And of course, needless to say, a physical exam is unbelievably important in our children and the parents' opinion, because the parents know the child very well.
Yes, yes, sure. Other signs and symptoms for cerebral palsy that we can see are positive and negative signs. Positive such as clonus or reflexes, but abnormal reflexes, and negative signs such as weakness, right? But when we talk about muscle tone, spasticity, sometimes there is spasticity, there is high tone, and there is low tone. So can you tell us the difference between them a little bit? And,
sure.
And normal muscle tone, what is the difference?
So the normal muscle tone, it's the average muscle tone that we have when we're resting, because it's not completely floppy when we are just sitting at rest, we're not doing anything.
Yes.
Spasticity, the definition of it, it's a velocity-dependent muscle contraction. So if the child is trying to move and tries to activate, then you get a very strong contraction that gets in the way of movement. And it's the same passively for physical exam. When I'm doing it, the faster I move it, the more forceful the contraction that I get.
Yes. Yes.
Low tone is the other extreme of the spectrum, which is the muscle is very floppy, it's very flaccid.
Yes.
So the very common pattern, especially at the beginning, after the initial brain injury, whether it's at birth or after birth, we get very flaccid or very floppy low tone. And then the children start to have higher tone around the arms and legs, low tone in the neck and back.
Yes.
And then it develops from there.
So we can say central hypotonia and peripheral hypertonia.
Exactly.
Yes. And sometimes also in clinical assessment for professionals, because also professionals are joining us. So there is a difference between spasticity and hypertonia. Spasticity is velocity dependent by definition, but hypertonia is there even if there isn't fast movements, and this has a huge impact on the decision of tone management. When there is a hypertonia or spasticity, it's different, and the causes also are different. Sometimes there is a tension from pain, from subluxation, from dislocation, which can manifest as hypertonia, but it's not pure spasticity from the muscle. Yeah, so people a lot of specialists talk in conferences about spasticity and what it is and hypertonia, and there is some difference, and that's why going to a specialist is very important, because to have your hypertonia or your increased tone diagnosed and selecting the proper method is very important. Yes. So what are the tools that you use to improve this tone?
So we have, thankfully we have quite a few options. And even with that, some children are more challenging than others.
Yes.
So of course, the very beginning, physical therapy, occupational therapy. So the techniques that you guys use, stretching, maintaining range of motion,
Yes.
neuromuscular facilitation, all of these things. That, of course, is the beginning of it. And then...
Yes.
If physical therapy needs some help, it's not sustained in between sessions or is still getting in the way, then we start talking about splinting. So we can prescribe knee immobilizers, AFOs, something to stretch the child when they're sleeping at night, because the theory is the children grow at night when they're asleep. And it's a passive stretch also for them as they sleep at night. So splinting and nighttime splinting specifically is one of the methods or the tools that we use.
Yes.
After that comes the role of medications. We have multiple medications that we use for spasticity management with different variety of effects and side effects.
Yes.
The one that we know very well and we use very commonly in children, exactly, is baclofen.
Yes.
Exactly. It's widely used because this is the one that we've been using for so many years.
Yes.
The people who taught me has been using it for so many years.
And it works.
It works and we know the effect of it.
Yes.
So to be honest, I use it sometimes, not as often as the local injections, of course, but I use it when needed. So many times I use it if the child is having too many spasms or if specifically at night they can't sleep because they're super tight and they need to be repositioned. So it's not uncommon for me to write baclofen at nighttime just to allow the period of rest and sleep.
Yes.
Of course, if the child is tolerating, they can take it during the day. But of course, the side effect of sedation and fatigue are always there.
Yes, because you said that it's in contrast with the local injections. So you are comparing. This is the first point of comparison.
Yeah.
This is systematic. When you take it, you might get other side effects.
Systemic side effects,
yes,
exactly.
Yes.
So, and the most common side effect is fatigue and sedation. Some children get used to it after a few days, actually, and it doesn't make them sedated anymore.
Yes.
But some, no, they never get used to it. For me, if a child goes to school, it's a reason for me not to give them baclofen because I want them to pay attention. I want them to be able to concentrate and perform at school. So some of the other children are not candidate for muscle relaxants to begin with. These are the children who have truncal hypotonia because you don't want to make this worse.
Yes.
And the children who have excessive salivation because again that would be affected as well.
Yeah. But this doesn't mean that every child with hypertonia and goes to school will not get baclofen.
No. Everybody's different, but that's what I'm saying. So because I know parents are worried about the baclofen because of the sedation side effect.
Yes.
And I do agree. And in that case, I would say give it at night. You know, or if the spasticity is affecting, and then it moves brings me to the next point, which is local injections.
Yes.
So if the amount of muscle groups affected by spasticity is not a lot, maybe only both legs or like one leg, then I wouldn't even think about systemic. I would just go for injections because it's easily treatable. We have have enough injectable medicine to put and have a nice effect.
Why give a relaxant to the whole body when we can give it to the
selected muscles?
Selected muscles.
Exactly. All the other muscle relaxants have similar side effects with different variety, of course. But again, we use baclofen very commonly in children. The option of local injections, we have actually two options. We have local nerve blocks, which is numbing pretty much the nerve that gives a certain muscle group to make it relax.
Yes.
Or we do Botox or botulinum toxin injections to the muscle itself.
Yes.
So these are the options for local injections. If all of these options has not been working, then we start to think about surgical options like the baclofen pumps or the selective dorsal rhizotomy.
Yes.
The other option that I forgot to mention was with the local injections, sometimes we use serial casting.
Serial casting.
The evidence is behind both together. I know serial casting alone can be effective, Botox alone can be effective, but when you combine them together, you get the best results.
Yes. Yeah. But that all of that is used with therapy.
Of course.
So this does not mean that when you get injection or when you get any type of these treatments, you have to do intensive therapy.
Yes.
And sometimes also it's popular that it's a misconception that you need to do only therapy after you get this intervention, after you get the injection or after you get you do the casting. But the preparation, the pre-operative stage is very, very important to condition the muscles, to condition the patient, to know the current state of the child, so that after that you are building up on more.
True. Yeah. And I have to say, therapy is very, very essential throughout. Yes. And because as long as the child still has growth, they will get taller.
Sure.
They will need you.
Yes.
And the injections. So for me, the outcome is actually better if the patient has been doing physical therapy for quite some time and they're not contracted. This is a huge point. Yes. If I'm only treating spasticity, the outcome is very good. Yes. If I'm treating contractures, it's going to take longer. It's going to, you can't predict the outcome as much.
Yes.
So that's why I emphasize physical therapy, occupational. They're very, very important all the time.
Great. So if we look at those tools that you've mentioned from baclofen and then the injections, Phenol and Botox, and then we look at surgical options. So baclofen is systematic. So then we have to deal with the other side effects.
Yes.
But and also when we look at surgical options, these are irreversible options. So you cannot bring it back, or you cannot take back your decision, right? But when you look at the injections, Phenol and Botox, this is a good option because it does not have the side effects of general sedation, and as well it does not. It's not irreversible. It is reversible because it stays for a specific time.
Yes.
So what is the time that Botox lasts and Phenol as well?
Okay. We'll start with the Botox first, or botulinum toxin. And the common name is Botox, but there's actually many types. There's Botox, there's Myblock, Xywamin, Ceox. There's quite a few.
A lot of
but for simplicity, and just a fun fact, it's the same Botox that they use for the wrinkles. It's the same exact Botox. There's no difference. So the Botox, it typically starts to work after 3 days. Maximum effect in 3 weeks, and it should last anywhere between 3 to 6 months.
Great.
So for some children, it can last longer. It depends on how quickly their body is getting rid of it. It's metabolizing it.
Yes.
And again, people forget that Botox is dose dependent. So the more Botox you put, the more relaxation or you're paralyzing the muscle more.
Yes.
The less you put, the less the effect.
Yes.
This is good to keep in mind.
Yeah, and these were sometimes that some patients have some misconceptions about paralyzing the muscles.
Yes.
They think that Botox will paralyze the muscle and paralyze the child, but this is completely not true.
No, and unfortunately, sometimes I wish it was that strong. It's not.
Yes,
it is not. So this is as far as the duration of the Botox. And I have to say, if it's only spasticity and then the child works with you and they get stronger, then they need less and less over time.
Yes.
The Phenol, it starts to work within 24 hours, almost right away, because
faster.
Exactly, because Phenol is alcohol, and I injected around the nerve that goes to a certain muscle group. Yes. So what it does is it demyelinates the nerves. It dissolves the coating of the nerve. So it disrupts the signal.
Yes.
So you see the effect.
But partially.
Partially, yeah.
So this is the difference. Like it's partially denervates the nerve, or partially makes the muscle more flexible, right?
It does, but the effect is stronger than Botox.
Yes,
because each nerve has many branches. So of course I cannot catch all the branches. I can catch the main stem, or like try, but I can't catch all of them. So usually you get, more relaxation than Botox. It's more instant than Botox. And it takes about 9 to 10 months to go away, because you're waiting for the nerve to remyelinate. Nerves do heal. They do come back.
Okay, that's another...
yes, they do
another
heal.
Surprise.
So this is another misconception, that nerves don't heal. It's not true. They do.
Yes, they do heal.
Yeah.
Yes. So the myelin sheath comes back. The covering of the nerve.
It does come back, and the nerve sprouts, which means it makes new branches to the same muscle.
Great.
So we heal in different ways. It just makes my job harder next time to find it, but it's fine. I'm okay with that. But it lasts longer. So, and the reason I talk about both together is, in most of our children, Botox alone is not enough. And that's why I say sometimes I wish it was that strong. It's not.
Because it is not as strong as the phenol. It's aiming for the motor end plate, or the part between the nerve and the muscle.
Exactly.
So it's causing like as a barrier.
Yes.
Which causes the muscle to not receive a lot of high signals.
Chemicals, exactly.
Yes, so that the muscle is more flexible.
Yes.
Yes, great. So do they have any adverse effects or disadvantages?
Of course, any medication, unfortunately. So Botox, the main, I want to say, so it has, if you look at Google, you would be scared. But the one that I've seen very often is the fatigue. It does cause the patient, whether adult or child, it does cause them to be tired the same day.
Yes.
And it can cause... almost flu-like symptoms, like you feel just tired, you want to sleep, all of that. The other common side effect is it can work too much, or it can work too little.
Okay.
So in that case, and that's why I'm very conservative when I do the injections for the first time. The first time I don't inject a lot, because I don't know this child's response.
Yes.
I inject the lowest indicated dose.
Yes.
Because I'd rather not have a big effect than make the child weaker, which goes with the, like, Botox makes the child not walk or something like that.
Sure.
I'm just getting to know the child. The more I know them, the more I feel comfortable giving more doses. We know how they respond and all of that. Yes. So that's the other possible side effects. The other side effects that we see in the books is fever, rash, diffusion to other areas. But thankfully, I have not myself seen it. Again, it's because of that. And 100% you need guidance when you do the Botox injections. 100%. Especially for the small muscles or the muscles that control the fingers. Because our children have muscle atrophy, they have rotational deformities. So the muscles are not always where they're supposed to be.
Yes.
Or you can go through and you don't know. So I highly recommend using guidance.
Like
either
ultrasound.
Exactly.
EMG.
Yes. Or electrical stimulation if the child is asleep.
Electrical stimulation.
Yes.
So how do you do that?
I prefer to do the injections under sedation because it's multiple injection sites, and I'd rather the child not remember any. Yes. And I need them to sit still to make sure it's going in the right place. So the electrical stimulation, you have the needle has electrical impulses coming out of the tip of the needle.
Okay.
So when I put it in the correct muscle, I see the right twitch.
Okay.
So when I see the twitch for that muscle and the appropriate function, for example, if I'm going for the finger flexors, if I put it here and I see this flexion, then I'm in the right muscle and I go ahead and inject. The EMG is you're listening to it. I rarely use it in kids, to be honest. I use it in adults more because you need the patient to be awake for it.
Yes.
And then ultrasound, of course. Ultrasound, you see the muscle.
The most popular, I think, thing used for guidance,
Yes.
the ultrasound,
Yes.
right?
Yes.
So electrical stimulation is a new modality or new way to guide injections, or is it?
No, it's just one of the options.
One of the options.
Yeah, I would say ultrasound is probably the newer ones.
Ultrasound.
Yeah.
Okay.
But electrical stimulation has been around for quite some time now.
Great.
Yeah.
Great.
Yeah.
Okay.
And I use the same method for finding the nerve as well, for the motor nerve.
For phenol injection as well.
Exactly. Yeah. Electrical stimulation.
Electrical stimulation.
Yes.
And then all of the muscles supplied by this nerve can contract, and then you know that you are on the nerve that you want.
Yeah.
Yes.
Yes, because so we have to be selective. It's very few nerves that we can inject with phenol. So the very commonly done ones are the anterior obturator for the gracilis and the adductors.
Yes.
So this is a very small branch that goes. So that I find with electrical stimulation. Also the medial hamstring. So you're looking for tiny bits,
Yes.
and then you're blocking those. Because again, you want to make the muscle weaker. You don't want it completely gone. Yeah. That's it.
So we are trying to explain for our audience all the side effects, everything around it. But it does not look like that when we see the patients after the injections. I have never seen any of these side effects with the children that had injections, Botox or Phenol, like fever, like rash. I haven't seen them also as well. Yes. Also, sometimes it says flu or something like that. No, I have never seen that. It's only localized pain. So it's a very simple procedure,
Yes.
right?
Yeah.
And we see the effects after only 3-4 days. It's completely different from our point of view, from physiotherapy point of view. We see a different child. Why? Because the muscles, when they are contracting, when there is hypertonia, it's affecting everything. It's affecting the body mechanics. Sometimes it's restricting the pelvis or the way they sit, the way they stand. So it's affecting their whole movements, and not only movements, also breathing. Sometimes they are restricted in breathing because of the tightness, because of the pain. Emotionally, socially, they are affected from all these ways. So the difference that comes when these muscles are relaxed is very big, and we see it in all domains and throughout all the therapies that we see.
It's amazing, and I think we're very lucky to have those tools to help the children.
Yes.
The phenol, I would have to say, so the phenol does cause pain for at least 24 hours after the injection, because no matter what, it's alcohol, the pH is different than the body's pH. So it takes time for the pain to go away.
Okay.
One time I had a child who had the pain for a week. But you're right. I have seen children who, for example, started talking after doing the injections just for the fact that they are more comfortable and they can actually focus and look at you and try to speak to you.
Yeah.
I've seen children who became more relaxed. They sleep better. They start singing when they're laying down. So it's very rewarding. Alhamdulillah, when it works, it's lovely. It really is.
Yes.
But I will emphasize that it's about the entire team approach. It's not just one thing. It's multiple things, really.
Sure. And when you're saying these results, that's when you inject, sometimes in the lower limbs, sometimes in the legs. You give this injection, and then it affects talking and breathing. So this is how it is related. But also injections can happen for the upper limbs, for the hand, to improve hand function, right? Yes. And also for the muscles of mastication, for the biting, exaggerated biting, right?
Yes.
What else?
Also, we do botulinum toxin has so many uses, but I'll speak about the ones that I use.
Yes.
Of course, to help with sometimes it's even torticollis. So the children who are stuck looking to one side, we can do that. Dystonia, which is the involuntary movement that the kids have. Sometimes sometimes it's forceful, that it can actually cause pain and instability and all of that.
Yeah. And I think about dystonia that so I heard it sometimes that it's used only in focal dystonia, but I think that is not true, because children who have dystonia all over their body, they need it for some muscles, which is causing the twisting movement, or causing more pain. Sometimes it's in the neck, sometimes it's around the hip. So even if the dystonia is all over the body, you also need to inject sometimes.
Yes. And again, it goes back to having a goal. Yes. It goes back to sitting together as a team and talking to the parents and observing the child and coming up with a goal that everybody agrees on.
Yes.
It works when it's that way.
Yes. Yeah.
It works because if you go ahead and just inject the dystonic muscle, or you go ahead and just inject the tight muscle, you don't get the same effect.
Yeah.
The other use for Botox that I utilize is salivary gland Botox. So for the children who have excessive salivation, and they drool a lot. Sometimes for social reasons at school, they get embarrassed, or with other children, or actually care. It's just they're constantly wet and they need to be wiped and all of that. So, and you have the other part of the children who are not able to swallow and they aspirate on their own saliva.
Okay.
So these two are indications for me to Botox the salivary glands, which is either the parotid or the submandibular gland.
To cause the secretions to be a little bit less.
Yeah.
So that will indirectly decrease the episodes of aspiration or all of that.
Yes.
Great.
Yes.
You mentioned about having a goal.
Yes.
And knowing which muscle to inject. So this happens after discussions between the team. What does that involve? It involves muscle tone assessment only? Does it involve functional assessment only? Does it involve
There's no only.
There is no only.
There's no only.
It's a comprehensive assessment.
Exactly.
Right.
So typically when the child comes to me, let's say the child, if the child comes to you guys, or usually I get the heads up from you, or if they come from our therapist, then I get heads up that, hey, I need help with this. I'm working on this goal and I need help with it. Of course, when the child comes with the parents, I take a full history, see what's difficult for the parents. What is the functional level of the child? GMFCS 1, 2, is it 4, 5? Where are we?
Yes.
And then physical exam is very important as well. I need to know, is the hip in place or is it subluxed? I need to know, does the child have scoliosis? What have they tried in the past? Have they tried medicine? Have they tried splinting? What have they tried? So I can pick up where they left off. And then if it's a walking child, I look at the child walking and see where is the impairment? Where is the instability happening?
Yes.
So
we analyze the way they walk.
Yes.
And see the pattern and see which muscles are causing this pattern or the difficulty with walking. Sometimes it's the walking is difficult because of a specific muscle. Sometimes it's a lot tiring for the children, and sometimes it's cosmetic appearance. It's not difficult. It's not energy consuming, but the way the child walks is different.
Yes.
And then Botox also is useful.
Yes.
Right.
Yeah. Yes. So actually the fatigue when they walk, this usually happens after a growth spurt because many parents, they come and they say she was walking fine or he was walking fine, but then a couple of months back he just stopped.
Yes.
And they can't straighten their knee and all that. So the children find it very difficult to advance their legs. And that's usually, of course, the hamstrings, like the back of the thigh. So we look at the children walking coming and going and from the side, and see where is the tightness, how is it affecting their gait.
Yes.
And then after that, I sit with the parents, I run it by the team, and I say, I'm going to inject these muscles, X, Y, and Z. I need to know the weight of the child also, because I am bound by the weight. The Botox, just like any other medication in children, it's weight-based.
Yes.
So the common dose used is between 10 and 15 units per kilogram. So if the child weighs 12 kilos, I have 120, for example, to use at the beginning. And again, it depends on the spasticity and all. So it depends on the muscle groups affected, what goal it is. Is it upper or lower extremities? Is it a muscle group that I can do Phenol for, or is it do I have to use Botox? Based on that, I come up with the plan. And then, again, confirm with the parents, confirm with the team, and then we go ahead and do it. If the child is able, then I confirm with them as well.
Yes,
and then we go for it.
For adolescent stage or children who are old enough to take their own decisions, they are of course included in the decision.
Absolutely.
Yes, because it affects their going to school, their how they live their life throughout this period of effect of the medicine.
And they need to know why they're doing this. It's their right. It's their body. Why are you poking me with needles?
Yes.
This is why.
Of course.
Yeah.
Of course. And after the injection, we start physiotherapy maybe in 3-4 days, just to avoid any pain at the site, anything, right?
Yep. So typically for the nerve blocks, we say no aggressive stretching, because the muscle relaxed all of a sudden. So we worry about a sudden tear if it's overstretched. Especially in nonverbal children, because they can't tell you, please stop.
Yes.
But we typically say just no massages for Botox as well, so it doesn't go other places. That's it. Usually only 3 days of no aggressive stretching, and then you can resume therapy, no problem.
Great. Yeah. And regarding therapy, we use different kinds of therapy after Botox, neurodevelopmental therapy, which is more focused on functional abilities of the child, and seeing the child through the 24 hours, not seeing the child physically through the 24 hours, but monitoring the child, knowing how they are sitting at home, how they're standing, how they're living their day, and then trying to modify the positions that they sit in, the way they are handled, so that they get the maximum effect of this. After Botox, we need prolonged stretching of the muscle, right? Which is the most effective way of stretching. We need to stretch the muscle in several hours, but that's not very painful. We use it in a specific range that is tolerable for the patient, and we use splints or we use stand frames, so the child is not only doing stretch and doing nothing. It's in a functional position. We sometimes do it in a sitting position, doing a standing position to stretch this specific muscle. That's for prolonged stretching. But also we do stretching in the sessions as well, which is functional stretching, to be able to teach the muscle and get the gains. So the gains is not only stretching the muscle and make it more flexible, because this effect of the medicine is causing the tone to decrease. But it's not affecting the flexibility. The flexibility comes when physiotherapy is applied on it. And then we can increase flexibility. So indirectly also as well, Botox can improve the flexibility of the muscles. And I have seen this for the children that we have injected lately as well, that their ranges, even after the effect of the Botox, have stayed better. Even after 3-4 months, 6 months, they have stayed better with consistent physiotherapy as well. Yes.
What happens is many times the children, they get more spastic after a growth spurt or after a period of growth. And of course it happens every once in a while. So when you give Botox and you catch it before the muscle itself becomes short, the effect is nice and it's long lasting. And I always tell the parents, you have to go to physiotherapy. Botox only takes the tone away, but it doesn't make the muscle longer. If it's contracted, you need to stretch it. You need to make it longer.
Yes.
And that's where like 100% they should come to physio. And if the range is actually like limited, then we start to think about serial casting.
Yes.
And I know that for sure when the children are sleeping under sedation, that's when you see the true range of the joint and the muscle. Because when you're asleep, you take the spasticity away.
Yes.
So I typically take ranges and pictures of the knees and the ankles, and I send it to the therapist or to the parents for them to have as record that when they're asleep, this is the range that we got.
Yes.
And it's a confirmation for me that no, we probably need serial casting, and I involved our orthopedic doctors.
Great. So even if the muscle has already gone through tightness, we can reverse that by the combination of injection with the bracing and physiotherapy after.
Exactly.
And also physiotherapy here is important because after injecting the muscle, which becomes a little bit weaker, and the bracing as well, which immobilizes the joints, then we need to build up more strength with the physiotherapy. So we're not only stretching, we're also strengthening because and we're not only strengthening the opposite muscle, we are strengthening the same muscle as well. Because any spastic muscle is weak. That's what we've learned. So we have to strengthen this muscle to be able to contract and relax, to be able to go through the full range of movement that it can move in. Also, not only the strengthening, but also the coordination. When to fire the muscle, when to activate this muscle, and at which time of the range. These are all gains that we can get when this window is there. When the muscle is not that spastic.
Yes.
Right?
Yeah, you have a chance to improve the child's perception of it, the motor control of it, how to use it, because it's not constantly tight and fighting them anymore. I'll give example. For example, the elbow flexors are usually very, very tight. If we do Botox, and there's more than one elbow flexor, so usually I don't Botox all of them. I Botox, it's very selective.
Yes.
So I'm taking the spasticity away. I'm not completely taking the strength away because I want to encourage more selective motor control. I want the child to pick up something and be able to extend their arm, pick it up, and then bring it back.
Yes.
So again, it all goes back to goal-oriented treatment.
Goal-oriented treatment, right? Is there any adverse events or any problems that can happen for the longer term after these injections?
Good you brought it up, yeah. Yeah, so one of the things I've heard is repeated Botox injections can give you muscle atrophy or muscle weakness, but that's the problem to begin with, isn't it? So the muscle is weak, the muscle is very tight, and it's restricting movement. The way I see it, if we delay the treatment, you end up with contractures. You end up with the child miss the chance of learning the appropriate way of walking. So from the long-term use of Botox, the only thing that I probably have seen in practice, and I heard it from other colleagues, is it might start to not be as effective. That's the real worry. And the recommendations now is to start alternating for a child who needs the injections every few months. We start alternating neurotoxins. So instead of using Botox all the time, we can alternate between Botox, Xyomin, Myoblock, whichever your preferred choice. Because the protein that's attached to the toxin is different. So your body takes time to develop the immunity to it. And that's why Botox doesn't work. It's because your body starts to develop an immune reaction to it, and it attacks it when you put it in. So it's not effective. So this is one of the recommendations to kind of get over that hump.
So after Botox injection, we need to also not only do physiotherapy. We need to also do occupational therapy. We need to do speech therapy, all kinds of therapy, so that the child can gain all the improvements that we were talking about. So because sometimes we see that a lot that parents come after the injection and tell us, well, we want to do only physiotherapy. We want to only do some kind of therapy, but not all the therapies that they will get. So looking at the child in a holistic way is very important. So physiotherapy is important, and having an intensive program after the injection is also very, very important. But excluding the other kinds of therapy is not the best option. Right?
No, it's because of that reason. It's if the child is more comfortable and they're more receptive, then you want to use the time and give everything you have, so you see how much they give back. This is the concept of it. That's all. And honestly, it's always a lovely surprise when you treat spasticity, but then something else gets better.
Yes, yes, of course. About SDR, can you give us a little brief about it?
So the SDR, it's a surgical intervention where the neurosurgeon goes in and tries to cut the nerves specifically responsible for the spasticity.
Yes.
Of course, it's a procedure. Not everybody can do it. It's a difficult one, and from my personal experience, this is a procedure that you really have to take your time selecting the right candidate for it, because you can't take it away, as you said. Backlift and pump, you can take away, you can take out. But the SDRs, you cannot take it away.
Okay.
For the children to be appropriate candidates for SDR, typically they have to be at a younger age. So in one of the papers, it mentioned between the age of 3 or 4 until 8 years of age. And the reason for that is walking is a habit as well.
Yes.
So you want to catch them before they develop the habit of walking a certain way. The other thing is the children should not have any contractures, no fixed contractures, and they should have enough strength underneath. They're not only relying on their spasticity to walk, otherwise they will stop walking.
Of course.
And the child has to be cognitively able to understand the instructions for physical therapy. They need to be able to follow commands and understand, and they have that control of their muscles, so when you tell them to do something, they can follow through. So typically, this is your criteria to select a child for SDR.
Yes.
And I want to correct one notion is if the child does SDR, khalas, they don't need spasticity, they don't need physiotherapy anymore. Unfortunately, that is not true.
No. Sometimes they need it more.
Exactly. So rehabilitation after SDR is unbelievably important, and it's usually very, very intense.
Yes.
But as the child grows, they might have, again, some spasticity that they need help. They might, or they may not, but it's a possibility. I've seen a few children who needed repeat injections probably 3-4 years after the SDR surgery.
After the SDR.
So it's not uncommon. It can happen. But if it's the right candidate for SDR, then the results usually are beautiful.
Great.
But that's the trick. Pick the right child.
Pick the right child and pick the right tool or the right choice of the tool. Yes. So other kinds of physiotherapy that we use before and after those treatments, we use also quivasmedic exercises, which is challenging the child to have better and more functional participation and functional activities, and to achieve higher skills. So it's a very interesting way of challenging the children in the physiotherapy session. And also we use electrical stimulation. Same as you, yes. We use it, but not in the traditional way of putting the electrodes and letting the electricity work on a static hand or static leg. No, we use it in task-specific electrical stimulation. So we use electrical stimulation at a specific position for the child to train the muscle on all the gains that we were talking about. Train it when to contract and with more strength, and to guide it in the specific direction that we want, so that we can get the best gains. So it's very interesting also tool for us, the task-specific electrical stimulation. So what are the take-home messages that you would want to say after this?
Take-home messages, I would say multidisciplinary approach is very important for children with special needs.
Yes.
Don't delay having your child be seen by someone who has expertise in the area, and work as a team with your child's therapists and doctors. I think everybody should work together for the best interest of the child.
Of course. And regarding the physiotherapy as well, doing the physiotherapy before the intervention is very, very important as a take-home message, and as well intensive program after the injection is very, very important. And we should not forget about the other therapies as well, because they are as much important as well. I'd like to thank you, Dr. Nadia, and thank all of our audience. It has been very interesting talk, and we hope to see you again, of course, in another podcast. And we will talk in the next episode maybe about other options that we can use for children. Thank you.